today's topic is insulin therapy. To go for a background, we know that diabetes mellitus, as rightly said, it has been a capital disease right now in the world with a growing incidence and prevalence. People surviving with diabetes has increased. People presenting with diabetes has increased. People presenting with complications has increased. And the ages have become lesser. Like we have seen that around 20-25 people coming with the diabetes, which is not type 1, so majorly type 2. So nowadays the insulin has got a very much importance in the therapy of diabetes. Why this is important? Because whenever you choose any treatment for the diabetes, especially the type 2 diabetes, there are few things you need to consider before choosing any treatment option, whether it is a drug. In the drugs, we have got many classification of the drugs, and you have got insulin. So we have got an OAD, that is oral anti-diabetic drugs, and we have got an insulin and other parenteral therapies for insulin. So whenever you want to choose between the OAD and an insulin or any parenteral therapy, you need to have few things in the mind for any diabetic patient. So when a diabetic patient comes to you, the newly diagnosed diabetes or a patient who is already diagnosed with diabetes on some treatment is not controlled, whenever you start treatment, you need to consider few things. So don't blindly start the patient on glimepiride, metformin, vildagliptin, not like this. So you need to consider few things. The first and foremost important thing is efficacy. What is the efficacy of the drug you want to start? What is the safety of the drug which you want to start? What is the cost of this drug? What is the side effect profile of the drug? What is the effect of this drug on weight? What is the CVO benefit, that is cardiovascular outcome benefit of this drug? What is the incidence of hypoglycemia with this drug? And very important is cost. Being in India, you need to consider the cost. You just cannot put the costly drug to a very poor patient. So you need to address all these issues. This is very, very important. For example, if somebody walks to you who is an 80-year-old who is diagnosed with the diabetes, comes to you, you just put him on glimepiride 2 mg, and very next week he will come with hypoglycemia, or he may die in hypoglycemia in the night. So these are very simple mistakes. A patient who is, I have seen patient who is 40-year-old presenting with 40 kg, the diabetes, people straight away starting them on dapagliflozin plus metformin. So both these drugs cause weight loss. The patient is already 40 kg, you are again increasing this weight loss. So this is a very problematic things when we consider the drugs. So we'll discuss this oral anti-diabetic agents in the other class. And along with this, few years back, only these were the factors which we used to consider whenever we have to choose the drug for the diabetes. Nowadays, there have been a tendency to choose or to concentrate on another area in the diabetes, and that is the beta cell preservation. We need our beta cells of the pancreas to be preserved. Why this is important? Because there have been studies which have shown that once the patient becomes the pre-diabetic, already 50% of your beta cells have vanished. And when he becomes the over-diabetic, 80% of his beta cells have vanished. This is, I'm telling about type 2 diabetes mellitus, not type 1. So even in type 2, when the patient becomes the impaired glucose tolerance or pre-diabetic, the 50% of the beta cells have lost functioning. By the time he becomes 80%, the 80%, only 20% are remaining to function. So this over a period, even this 20% will get lost. So can we prevent this 20% loss of beta cells? So if we can prevent this 20% loss, we can prevent the patient of type 2 diabetes to become advanced diabetic, wherein he require an absolute insulin therapy. So insulin for a diabetic, for irrespective of the type of diabetes, will be required. even in type 2 diabetes mellitus, after a few years, he is going to become an insulin dependent diabetes. That is what the tendency is now. So from the beginning, if at all we target this beta cell preservation, why? Because there has been studies which have proven that beta cells in this stage are not dead. They have not gone into apoptosis. They are just stunned. So they are stunned beta cells. Like a stunned myocardium, we have got stunned beta cells. So why this stunning occurs? Because of glucotoxicity. A very high circulating blood sugar concentration suppresses the beta cells, so they will become stunned. So if you control your blood glucose in a very initial stage of a very intensive control, so this stunned beta cells may regain function to become activated. Then you will have a very good lifelong diabetes control if you control this beta cell, if you preserve these beta cells in initial therapy. So one of the very important drug or the treatment which preserves beta cells is an insulin therapy. So there has been an incidence nowadays that people are straight away starting with insulin, even for type 2 diabetic patients, if the patient is willing, if the patient is explainable, if you can explain this, if the patient is willing, especially for some initial 3 to 4 months. So this is the latest in insulin therapy. So that's why insulin therapy is increasing recently. It is just not the glimepiride, metformin, etc. So to go back the history, insulin was the major scientific breakthrough of the 20th century, which is the biggest achievement of the humanity. So the credit goes to these 4 scientists, basically these 2, the Banting and the Best. The Banting, as I was telling you yesterday, he was an orthopedician. Many of the orthopedicians present right now may not have any interest in diabetes, but the orthopedician in the year of 1921, Mr. Frederick Banting, got somehow interest in diabetes. So before Banting and Best started work, we know that Langerhans was a scientist who established that there is an organ called pancreas in the body, which has got this exocrine and an endocrine function. Endocrine function is done by these islets of peculiar cells called islets of Langerhans. And what they demonstrated was, in dog, they removed the pancreas, and after removing the pancreas, these dogs started urinating very frequently. And these were trained dogs, and they could not prevent them from frequent urination. And when they tested for this urine, it was showing sugars. So this was known part till the Banting and Best started to work on this. So what they did was, they removed the pancreas from the dog and they preserved this extract, pancreatic extract from the endocrine, that is the islet cell, and they re-injected it to the dog. So when they re-injected it to the dog started, or dog prevented from frequent micturition. The micturition frequency reduced and the sugar decreased and it disappeared from the urine. Then they got to know somehow that there might be some factor in this pancreas which is controlling our blood sugar. But this Banting, along with the Best was a student from McLeod. They did not know how to extract this particular product from the pancreas. So they went to their professor called Professor McLeod. Professor McLeod was the senior physiologist, had a good amount of experience in the research activities. What he did was, he assigned this person, that is James Collip, to this University of Toronto, the Connaught Laboratory, to work with the Best and Banting to help them to extract this particular factor. So this Collip helped them. He was a biochemist, so he helped them to extract this product from the pancreas ultimately, and they labeled it as insulin, where insula means an island. So this was the first insulin which was came into existence. And for this, in the year of 1923, exactly 100 years earlier, they got the Nobel Prize, and it was shared between these four individuals. Actually, this was given for Banting and Best, but Banting and Best decided to share this amounts. And another very good thing about Banting is an Eli Lilly company, who was the first company to manufacture insulin, got to know about this production, and the patency was at the Banting. So Banting gave this permission to Eli Lilly for just $1. So that was the greatness. If it was done today, it would have been like multiple crores. So this was the first patient to treat with the diabetes. The first person to get insulin is different. First person to get insulin is Banting and Best itself. What they did was, when they extracted the product, they injected it themselves, and they had the symptoms suggestive of hypoglycemia. So this was the first patient who was given the life expectancy of just 3 to 4 weeks by the doctor. He was started this insulin after consent from his father. Then this is what is he after 2 to 3 months of an insulin therapy. So there was a rapid improvement in the patient of type 1 diabetes with the insulin administration. So Indian history again comes back after a few years from 1923. So the main name comes is Dr. J.P. Bose from the Calcutta, who was a pioneer in insulin from India, and he was the first doctor to use insulin in India. And this is one of the first named patient. Kumadini was a 12-year-old girl to receive insulin from India. She is not the first person to receive insulin from India. There are other persons, but their names is not being mentioned in the history. The Kumadini was the first named person who is mentioned in the history. So from this 1922 recent times, there has been a lot of advancements in the insulin production. Initially, we used to be dependent on animal for an insulin extract from the pancreas. Initially, we used to get the bovine insulin, and later it was transferred to the porcine insulin, as structure was fairly similar to the human insulin. Then after this, the recombinant DNA technology came into existence after the Frederick Sanger gave the complete structure of the amino acids in the insulin. The recombinant DNA technology came into existence and started to produce insulin without any use of the animals. So the human insulin is a peptide hormone, the polypeptide hormone, which has got 51 amino acids in total, which is divided into 2 chains, the A chain and the B chain. The A chain has got 21 amino acids, B chain has 30 amino acids, and both these chains are linked together by this disulfide bonds. There will be some amount of difference from the animals to the human insulin. The closest to the human insulin is porcine insulin, but problems with these insulin is the antigenicity. So since they are foreign material to the human body, the human body starts to produce antibodies to this animal insulin. So they cannot be used for a very long time. But the problem is not existent right now, because we never use an animal insulin now. We are using the human insulin. So we know that any protein to be produced, there has to be an mRNA coding. So this particular mRNA, which encodes for this pre-pro-insulin, comes to this rough endoplasmic reticulum to get transcribed into pre-pro-insulin. And this pre-pro-insulin gets cut at a particular site and divides into two parts. One is pro-insulin. This pro-insulin parts get transferred into Golgi apparatus in the beta cell, and the signal sequence get excluded from the part. And this pro-insulin in the Golgi apparatus gets cleaved at a particular site to make it into 2 parts. One is an insulin, which is an active part, metabolically or physiologically active part, and a C-peptide, which is an inactive part. So for every single molar unit of insulin, there is an equivalent amount of C-peptide produced from the pancreatic beta cell. So the importance of this is, if you want to know that how much of insulin is produced from the body or beta cells, you can just measure the C-peptide. So amount of C-peptide will be equal to the amount of insulin produced. So the C-peptide level is a marker of an endogenous insulin production. So you want to know whether this person is producing insulin or not. Like, you want to differentiate between type 1 diabetes or type 2 diabetes. We know that type 1 diabetes is an absolute insulin deficiency, whereas type 2 diabetes is because of an insulin resistance. So type 1 diabetes patient will not produce any insulin. So that's why their C-peptide will be undetectable or very low in the body. Whereas type 2 diabetes patient, because of insulin resistance, C-peptide may be normal or high. So this is how the C-peptide can be an endogenous marker of an insulin production of an endogenous marker, especially in type 1 diabetes, except during their honeymoon period. This is very, very important. So we know that for any diabetic patient, we want these things to be in control. Initially, we want the HbA1c itself, if it is controlled, then it is well and good. That's what we used to believe earlier, because for every 1% reduction in HbA1c, there was a macrovascular protection in delaying the complications. And we know that the fasting blood glucose and the postprandial blood glucose will target. But along with this, a few other things were expected, that glycemic variability. So this is a very, very important thing right now, has come into existence. Even in a patient with normal HbA1c, if he has got a very huge glycemic variability, sometimes it's very low, sometimes it's medium, sometimes it's very high. So this is called glycemic variability. Your glucoses are varying from day to day life, even with a proper treatment. Then it is an independent risk factor for CV mortality. That's why they have told. That's what they have told. That's why the CGM have come into existence. It is continuous glucose monitoring, where time in range should be in target. Along with this, the quality of life, we want the patient, irrespective of any disease, we want our patients' quality of life to be very good. They need not to be any compromise in the patients. We have seen many of the patients who are type 1 diabetic are losing their job just because of insulin, or some children who have to leave the school just because they cannot take the insulin. So to come the insulin, the commercially 3 types of insulin are available. We have got a human insulin available, and we have got an insulin analogs. So human insulin is a insulin which is very similar to the endogenous insulin, except it is produced from the recombinant DNA technology. And insulin analogs are insulin where there will be some modifications in the structure to the human insulin. Either there might be an addition of a new amino acid, or there might be a replacement, or there might be inversion or deletion. Anything can be there. Biosimilars, we know that they are copycats. So similar to the biological agents, biosimilars for the insulins are available from the market at a very cheap price. The one FDA approved biosimilar is a insulin glargine. Right now we are using for a very low price, which has been available in Jan Aushadhi. Similarly, some premixed varieties are also available. So there are 3 types of human insulin which are in use. One is regular insulin, which is very similar to this structure. The next is an NPH insulin. We know what it is. Then a U500 regular insulin. And insulin analogs are like a rapid acting insulin, the basal insulin, some combinations, etc. So whatever the insulin which are available in the right now, they just differ largely in their pharmacokinetics. So this alteration in the pharmacokinetics can be done by 2 things. One is you just change the molecular structure, or just you attach another moiety to this insulin. So what happens is when you give an insulin, so for example, these are the blood vessels and this is the subcutaneous tissue. When you give insulin in the subcutaneous tissue, what happens is to cross the capillary barrier and to enter into the capillaries, the insulin has to be either in the monomer form or in the dimer form only. So if you make this a hexamer or a polymer, then you cannot make this transferable to the capillaries. So whenever the insulin is given, the insulin molecules, they form dimers or the tetramers or the hexamers. And then what happens is these dissolute the insulin molecules to the monomer and the dimer, then just slowly gets released into the capillaries. So this is what the basic funda in altering the pharmacokinetics. So if the insulin is in the monomer form, no problem. If you give into the subcutaneous tissue, it will straight away it will be absorbed into the capillary. If you have got a hexamer, like if you attach a zinc moiety and if you created a hexamer of an insulin, or if it is a dihexamer or if it is a multi-hexamer, the more the complex the structure, the absorption becomes more slow. So this is what is how you alter the insulin structure here. So for this insulin to give, the insulin was produced from the various companies. Nowadays, we have got many varieties of insulin. There is no problem with the availability of insulin. The world is filled with the insulin. But the main problem with the insulin is we have to replace this insulin in a physiological pattern of an insulin secretion. So how the insulin gets secreted into the human body? Actually, there are two problems when we give insulin from the exogenous. The one is to replace it from the physiological section. So the physiology, what happens is normally there is some amount of insulin secretion from the pancreas. So this is called as basal secretion. This is irrespective of your meal pattern. Some amount of insulin will be secreted from the insulin. So this is very important to inhibit an excessive hepatic gluconeogenesis. If this basal insulin is not there, you are in fasting state, the liver start to produce glucose in a very high quantity. So to suppress this, the insulin will be produced in a very low amount at a basal rate. And whenever you take a meal, like there is a tendency to take 3 meals. So if you take a breakfast here, after eating some breakfast, the glucose which is being there in the food stimulate the insulin. So this is called meal-related insulin secretion. And this will come to normal after some time. Again, if you take a meal here, there will be an insulin secretion. Again, after a meal, there will be an insulin secretion. So there is some amount of basal secretion. Along with this, the prandial insulin gets secreted from the meal-related insulin. And this prandial insulin gets secreted in 2 stages. First stage, there is an initial rapid stage. This is called stage 1 of an insulin secretion in a prandial state. Then after that, there is stage 2. So this stage 1 is mainly due to pre-stored vesicles will get secreted. Then there is a new formation of insulin. So there has been a scientific proven theory that the first abnormality that occurs in diabetes is delayed first phase of insulin secretion. This might be an entrance question. The first abnormality that occurs in diabetes is a delayed secretion of phase 1 of insulin from the beta cell. So to replace this, when we give an exogenous insulin, to replace this physiological secretion is very, very difficult. Let's see how to achieve this. And there is another problem with the insulin. As I told you, there is a background secretion which is low and which is stable between the meals. Along with this, there are prandial surges. So you can see that there is a surge here, there is a surge here, there was a surge here, and there is a minimum amount of insulin which is always there in the body. Along with this, there is a problem. What problem is, whenever the pancreas secretes an insulin, it enters the portal circulation first. Then it goes through the liver. Then it goes to the systemic circulation. So the insulin which is secreted from the pancreas first appears in the liver, where the 70 to 80% of your secreted insulin is utilized by the liver to suppress its hepatic gluconeogenesis and to prevent the glycogenolysis. Only 20 to 30% of this insulin gets expelled into the systemic circulation, where it tries to act on the adipose tissue and the skeletal muscle. This is more than sufficient. So, but what happens when you give insulin exogenously? When you give an exogenous insulin, first you are reaching this insulin to the systemic circulation. Then, after this utilized systemic circulation, the amount of insulin that enters to the liver is very, very low. So, there is a resulting abnormality to suppress the hepatic glucose sufficiently. So, whenever you give an exogenous insulin, even if you can give it like the physiological thing, you cannot make this things to change, because you are first giving it to the systemic circulation, then giving it to the liver circulation. So, exogenous insulin administration causes two abnormalities which are very difficult to cure. One is there is a systemic hyperinsulinemia, and there is a portal hypoinsulinemia, which is a very, very, very difficult thing to address even now. So nowadays, that's why the hepatoselective insulins are coming into the market. That is, we will discuss when we go into the slides. So how you classify this insulin? I have told you that whatever the insulin which are available vary only in their pharmacokinetics. So these insulins are classified as either mealtime insulins or the basal insulins. In the mealtime insulins, we have got the human insulin, that is a regular insulin. Then you have got an insulin analogs. So analogs are, there might be slight change in the structure to the human insulin. So there are three rapidly acting insulin which are available right now. One is the Lispro, another one is Aspart, another one is Glulysin. And I have given you the trade names also here, the Humalog, Novolog, and Apidra. So how this pharmacokinetics differs from this regular insulin to this rapid acting insulin. So the regular insulin, which is similar to the human insulin, whenever you give it in the subcutaneous tissue, it itself transformed into hexamers. So it has to be converted into the dimer and monomer to get secreted into the capillaries. So it takes some time. That's why the onset is 0.5 to 1 hour. So whenever you give this regular insulin, the onset, the action of this regular insulin starts only after either 30 minutes or after 1 hour sometimes, if your subcutaneous tissue is very, very thick. And there is some amount of peak after 2 to 4 hours. It reaches to its maximum function at 2 to 4 hours, and it acts for around 4 to 8 hours. So this was the regular insulin. The insulin Lispro, Aspart, Glulysin, instead, they are very rapidly acting because they are directly in the monomer form. They do not go into hexamerization when you inject into the subcutaneous. So when you give into the subcutaneous tissue, their onset starts within 10 to 15 minutes. And they reach peak early to the regular insulin, that is within an hour or 2 hours. Then within 3 to 5 hours, their action will be over. So that's why you can give these insulins with a meal or as a bolus insulin, or also called as prandial insulins. Now there are other types of insulins called basal insulins. So there are two types of basal insulins. One is an intermediate acting, that is an insulin NPH, neutral glutamine hagidol. Next, you have got long acting insulin analogs. So there are mainly 3 long-acting analogs, that is glargine, detimer, and digludec, and one concentrated form of glargine, that is U300. We will understand this. So insulins one by one. So first we'll try to understand this short-acting insulins, or prandial insulins, or meal-related insulins, or bolus insulin. All are similar. Don't get confused by the name. So why? Because these are usually short-acting or rapid-acting. So we use them only with the meals because of their short duration of action. So there are, as I told you, there are two types of insulins which are prandial. One is either you can use a regular insulin or you can use a rapid-acting analogs. So regular insulin, as I told you, that it is very much identical to an endogenous insulin polypeptide. And in solution, it self-associates to form a hexamer. Hence, its action starts only after 30 minutes. So why it is important to know this? Because its action starts only after 30 minutes of an injection. So if at all you want to take some food or breakfast, you need to inject it 30 minutes prior taking a breakfast. This is why it is important. And another problem with this, its peak is after 2 to 3 hours. For example, if you take a breakfast at 9 a.m., you have to inject this insulin at 8:30 a.m. So you're injected here, you started breakfast here. Your breakfast insulin is like this, meal is like this. So what the problem with is, the action starts after 30 minutes and the peak is after 2 hours. So the regular insulin actually does not exactly mimic your physiological meal-related insulin production, because it has got a delayed peak and slightly longer duration of action. So what happens is, there is usually an early postprandial hyperglycemia because insulin has not yet started to act. It takes some time. So there is an early period. Even if you measure your blood sugar immediately after breakfast, it will be very high because its action has not yet started. And after some time, like after 2 hours, if you measure this blood sugar before lunch, there will be a late hypoglycemia because there is no meal in the body, but your insulin is at its peak action. I think you understood this very important point about a regular insulin. If the regular insulin, the problem is you have to take before 30 minutes and its action profile does not match with an endogenous meal-related insulin production because it has got a delayed peak and a slightly longer duration. Therefore, the issues are, you have got an early postprandial hyperglycemia because its action has not yet started, and since it has got a late peak and little bit longer duration of action, it will have a late effect of hypoglycemia. So this is a very, very important problem. So many of the patients who are on regular insulin, if you ask them at 1 p.m. exactly, if they are taking insulin before breakfast at 1 p.m. or 2 p.m., they will get a symptoms just of hypoglycemia. Like, I cannot postpone my lunch. I work as a security guard. Suddenly, I feel sweaty. I feel palpitations to occur, etc. So this is a major problem with this regular insulin. We have got this particular type of regular insulin available in the market, or presently it is being very less used. This is U500 regular insulin. So what was the usual concentration of this is every ml of an insulin contains 100 unit of insulin, but this they made it more concentrated. Every 1 ml of an insulin U500 contains 500 units. So they made it more concentrated, but this did not gain any popularity. It got disappeared from the market very rapidly. So how this rapid acting analogs are comparable to the insulin regular, if you see. So unlike the regular insulin, they're absorbed very rapidly after injection because they directly dissociate into monomers instantaneously. So the advantage is they can be given just prior 10 to 15 minutes to the breakfast. So there will not be too much delay. So there is no problem with the rapid acting insulin. And their peak is also exactly at the 2 hours. So does not have any prolonged period of action. That's why they usually does not have the risk of hypoglycemia, and they have a better control of this blood sugar. And sometimes what happens is they can be given after the meal also. So there have been some modifications in the insulin, rapid acting insulin, which are called as an ultra rapid acting insulin. So there are two types of ultra rapid acting insulins available in the market. One is the fast acting aspart. The aspart is rapid acting, whereas fast acting aspart is very rapidly acting or ultra rapidly acting. Another one we have got a Lispro, AABC. So there is some amount of modification in the Lispro and asparts to produce them very rapidly acting. So what is the advantage of this ultra rapid acting insulins is they can be injected even after meals to control the meal related hyperglycemia in diabetes. So this is the FMAS, a very commonly available ultra rapid acting insulin. This is an insulin aspart that is a fast acting aspart. So normal aspart is available as a Novolog, whereas fast acting aspart is available as a FMAS. Very commonly used, especially in children's who are very adamant, who are school going, and whose meal pattern is very haphazard. So, for example, if the patient you have kept on regular insulin, and if the patient did not consume any meal, so again he will be going into hypoglycemia, very, very importantly. But this is not the problem with rapid acting or ultra rapid acting. You can give them even after meals. So there will not be any problem with the skippage of a meal or risk of hypoglycemia is very, very less. But what is the problem with rapid acting analogs is the cost. The regular insulin is available just for 100 rupees, whereas the rapid acting insulin, the FMAS, this cartridge contains 1,200 rupees. So the only problem with the cost. So if you can afford, then it is better to go for a rapid acting insulin. If the cost is the issue, then the regular insulin you have to advise to the patient, and you have to strictly advise them to adhere to their mealing patterns. Now you have got the basal insulins or long acting insulins, where we want to mimic the basal insulin production from the pancreas. As I told you, there is some amount of insulin which is always produced from the pancreas to maintain to prevent the hepatic gluconeogenesis. So there are two types of insulins. One is an insulin NPH and the long-acting analogs. So what is an insulin NPH? Insulin NPH is simply the human insulin only, but they have made it a little bit complex. So they have combined this protamine and zinc in a phosphate buffer. So this property of adding this NPH makes it very gradually getting absorbed from the subcutaneous tissue. So it is not like a rapid acting insulin where it gets within 2 to 3 hours and after 3 to 5 hours it is low. It is not like this. It makes it a little bit a longer acting, where its its action starts 1 to 3 hours after an injection. So you have given injection here, its action starts after 1 to 3 hours, and it reaches peak in around 4 to 6 hours. Then it comes for around to the baseline by around 12 hours. So NPH is usually used as twice daily because its action is for around 12 hours, as I told you. Sometimes it can be given once orally, especially we have tendency to use them in especially the cases of GDM, the gestational diabetes. But NPH is usually given twice daily. What's the advantage of this insulin? The NPH insulin can be combined with other insulins. There's no problem, whereas other long-acting insulins is very difficult, especially the glargine you cannot combine with any insulin, and the price is very, very low. It is around 120, 130 rupees the vial, whereas the long-acting analogs are very, very costly. But the problem is it is to be given twice daily, and there is a definite peak. So as I told you, the basal insulin secretion. So you have got a basal insulin secretion. It is peakless. There is very slow production of insulin. In normal humans, it will never cause a hypoglycemia. So, but NPH has got peak. So it cannot mimic your basal pattern of insulin secretion. So it is like this. So at this particular point of time, there is a definite tendency to go into hypoglycemia, the peak. So that's why it is very difficult to mimic the physiological insulin secretion with the NPH. So this is a very common scenario. I want you to name this phenomenon. So whenever you're like an example that NPH you are given 16 units in the night. So the patient woke up with a history of a bad dream, with a sweating, drenched in his sweating. And when he woke up in the morning at 6 a.m. or 7 a.m., he checked his blood sugar. It was around 500. He went to doctor. What he did was he increased the previous night NPH to 20. So this today night he will take 20 units. So what will happen tomorrow again? So what is this is? This is what is typically called as somyogi. So this is a somyogi phenomenon. So here, if you are given NPH, as I told you, there is a delayed peak. If especially if the patient is on NPH, we usually advise them to take a snack before going into bed. So if he missed the snack, what happens is in the late night when there is a peak of this NPH, especially if he has consumed less meal in the night, or if he has not taken the bedtime snack, so there is a tendency to go into hypoglycemia in the early morning. So this 2 to 4 a.m. is a very high risk of hypoglycemia, and after hypoglycemia there is a rebound increase in the counter-regulatory hormones to cause an early morning hyperglycemia. So this is a typical somyogi phenomena. The treatment of this is the reduction of the night NPH dose, not the increasing the NPH dose. This is very important. You may cause death of the patient if you increase this dose. So whenever the patient comes to you with a typical early morning hyperglycemia, the first thing you need to ask is history of nocturnal hypoglycemia. Sometimes it's available, sometimes it's not available. Even if it's available, it will be very vague, like patient might have a bad dream and he woke up, he had passed in the urine, he had huge sweating, etc. So the next night you ask them to measure 2 to 4 a.m. blood sugar and prove that it is a somyogi phenomena, and the treatment is reducing the NPH dose of the night. So why this occurs? Because NPH, even if we use it as a basal insulin, just because it is a little bit longer acting, it cannot act as a basal insulin because it definitely has got a peak of around 4 to 5 hours after giving an injection. So that's why it is very important to understand the night dose NPH importance here. Now to deal with the problems of this NPH insulin, we produced some of the long-acting analogs. So the first long-acting analog was Glargine. It is my favorite. So it is the only acidic insulin, or like you cannot mix this insulin with any other insulin. So whenever this insulin is given subcutaneous tissue, it forms the self aggregates with a slow dissociation of near 24-hour. So hence the OD dosage is possible. Once you give this insulin, it will tend to act for around 24 hours. Some have claimed it against the true peakless effect. So initially, like 2 to 3 hours, 2 to 3 years before, we used to believe that it is a peakless insulin. We thought that it is like this, whereas it has been proven again nowadays that there is some amount of peak with the basal insulin, that is Glargine also, and it usually does not act after 20 hours. So there is some amount of gap the next dose whenever you are giving it at an OD dosage. Like usually we have a tendency to give glargine at night time. So you are given insulin at 9 p.m. The next day you are advised him to take at 9 p.m. Because we used to believe that it acts for 24 hours. But now it has been proven that it usually acts for around 18 to 20 hours. So for this 4 hours, there is an hyperglycemia occurring in the body. So this is usually called as dusk phenomena. So to deal with this, what they did was they prepared a concentrated solution of a glargine. So in routine insulin glargine, we had 100 units per ml, but this special bacillus, that is glargine, has got 300 units per ml. So they have claimed this U300, that is a very famous 2GO. You have been very frequently using 2GO right now. The 2GO claimed to act for 24 hours. That's why OD dosage is possible. Sometimes for the type 1 diabetes, we have given this glargine insulin twice daily also, who are not controlled, who are having a very high requirement of insulin, but it is usually advised at the OD dosage. 2GO is a very good insulin for this 24-hour coverage. But if you compare, there is comparative study between the U100 glargine versus the U300 glargine. And if you see, there is actually no much difference in glycemic control. However, the hypoglycemic effect, that is what they have told you. Otherwise, there is no significant difference between U400 and U100 scientifically. Then there are other fancy long-acting insulin, that is the DMAS, available as Levimid. So this is similar to NPH, acts for around 12 to 14 hours. So what they did is in structure is they added some amino acids and a fatty acid to the beta chain. So it makes it binding possible to an albumin in the subcutaneous tissue. So this binding delays its absorption. So detimer is usually given twice daily, like NPH, but like NPH, it does not have so much of peak. The peak effect is less. So the hypoglycemia effect, if you compare this detimer with NPH, is definitely less. If you compare detimer with glargine, detimer is a little bit shorter acting compared to the glargine. And this insulin degludec is also as an ultra long acting insulin because it forms the multi-hexamers aggregates in subcutaneous tissue. I think I gave the multi-hexamer formation example here. So the multi-hexamer formation was basically for the degludec. This is the ultra long-acting insulin. So the half-life of this is 24 hours. So half-life itself is 24 hours. So it has got duration around 42 hours. So what's the difference between degludec and glargine? So glargine is given 24 hourly, but at a very strict time. Like if you advise them to take at 9 p.m. daily, they have to take it at 9 p.m. Or if you advise them to take at 9 a.m., they have to take it at 9 p.m. You cannot miss the dosage here. So the dosing flexibility is not there. You cannot miss the dosage here. But the advantage of degludec is there is some amount of flexibility of the variable timings within the 24 hours. Like you advise them to take in the 9 a.m. You are taken today at 9 a.m. Tomorrow, if he's traveling, if he forgets his degludec, he can definitely take insulin at around 12 a.m. or around 1 p.m. after lunch, etc. So like this. So there is some amount of flexibility. But what is the problem with this insulin is, if the patient takes it at exactly 24 hours, like he is taking it exactly at 9 a.m., 9 a.m., 9 a.m., there is some amount of insulin stacking occurring in the body. So this insulin stacking at this overlap period of double dose of insulin can increase the risk of hypoglycemia. So you need to be very, very careful here. So this is a very famous trade name of insulin that you might have heard, that is Tresiba. Comes in its own pen formulation. The Tresiba, the pen costs around 5,000 and the insulin vial costs around 1,500 rupees per vial. So it is costly, very much non-affordable for the people of poor classes. So you need to decide which insulin to the patient to be kept on. So to again understand the duration or mechanism of action, the regular insulin, that is U300, is a short-acting insulin, and you have got rapid-acting insulin. Two insulins for the meal-related pattern. The problem with regular insulin is it action delays. It has got a little bit delayed peak, so the meal-stimulated endogenous insulin secretion cannot be matched with the regular insulin secretion. Whereas rapid insulins like Lispro, Aspart, Ulyssin can have the little bit similarity to the endogenous secretion, especially the ultra long acting like the FMAS are very much similar. Like even these insulins can be taken immediately after meals. Like if the patient wants to have some snack, let the patient have some snack and take this insulin shot. This is very, very useful for the pediatric population that we have seen right now. Now, if you want to take the long-acting insulins or the basal insulins, you have got an NPH, also for intermediate acting, to be given either twice daily. The problem with this is the peak effect. After some 5 to 6 hours, there is an increased chance of nocturnal hypoglycemia and the samyogi. And the glargine, see this, they said they have given a very nice comparison between the U100 and U300. The U100 effect slightly wanes off after some time. Sorry, this is U300. It slightly wanes off after around 20 hours, whereas U300 is comparable to the ultra long acting drug like degludec. So if you take this insulin, the only insulins which are mimicking the physiological basal insulin secretions are U300, that is 2GO, or Tresiba, that is degludec. Now coming to the pre-mixed insulins, not a very big fan of this in personal. We have got two types of pre-mixed insulins available. We have got conventional pre-mixed insulin, where it is usually a combination of the regular insulin and an NPH insulin, that is a short-acting insulin or plus an intermediate-acting insulin in the variable concentration. And we have got pre-mixed insulin analogs also. Here it is an analog combination of an rapid-acting insulin plus long-acting analogs. So you have got conventional pre-mixed insulins. You might have heard these names: 30-70, 50-50, and 25-75 very rarely. 30-70 means 30% is short-acting, that is regular, and 70% is NPH. And 50-50 means both are at the equal proportion. Whereas various combinations of analogs are available, like we have got a combination of Lispro and Listroprotamine in a combination of 25-70 or 50-50. It is available as the homolog mix. Then you have got no mix 30-70. It is a combination of aspart and aspart protamine. Then you have got a Rhizodeg, it is also called as IDEG aspart. It is a combination of a degludec and an aspart. These are the analog mixed insulins. So what is the pre-mixed insulin advantage? Advantages is the lesser injection, and believe me, this is the only advantage. This is the only advantage of the regular insulin. Otherwise, premixed insulin. Premixed insulin, except for the number of lesser injection, does not have any advantage. The fine tuning is not possible. Why? Because, let me give an example here. So there is a patient who takes this 30/70 insulin. So here what it does is 30 part. So this is an example 30/70. Here the 30 part regular insulin has got the peak at 2 to 3 hours. Then the basal action is carried by the NPH insulin. So if the patient has taken the meal here and he has injected some 12 units of 30/70 insulin. So this effect is like this. Now again in the night, he has taken the insulin. Night time effect is like this. So here the patient need to have a very strict meal pattern. He cannot miss his lunches. He cannot eat extra. Because the very fine tuning of this is very much not possible for this premixed insulin. If you want to, for example, if the patient has a persistent post lunch hyperglycemia, how will you adjust the insulin dose? Persistent post lunch, if you increase the dose, you will have a hypoglycemia at 12 p.m. If you decrease the dose, the post lunch will again increase. So because the fine tuning is definitely not possible here, there's a very much risk of this nocturnal hypoglycemia because it has got NPH, especially if you miss a mealtime snack. So here you need a diet changes for the insulin, not the insulin changes for the diet. So this is not been possible for the children. So one type of diabetes where you cannot use premixed insulin is, remember, type 1. Type 1 insulin not at all advisable. Not at all advisable. Only if we prefer the premixed insulin type 1 diabetes. After explaining all these things, if you can adjust his meal pattern, is working, it is not possible for 3 or 4 injections, then only you go for premixed insulin in type 1 diabetes. Otherwise, if a type 1 diabetes, you keep him on premixed insulin, definitely he is going to worsen. Remember this. So this is how they act. If you take the mixed here, the short acting part acts for some hours and the long acting part takes for some hours. So you have to take this 3 meals and 3 snacks. Three meals and 3 snacks is must if patient is on premixed insulin. So till now we understood what are the types of insulins are available. So what are the indications for insulin? We know that type 1 diabetes, you need to give insulin because they're absolutely insulin dependent. The next very important is secondary diabetes, that is pancreatitis or the drug induced, especially the steroid induced. It is better to keep them on the insulin. The gestational diabetes, especially if the targets are not achieved. What was the target in gestational diabetes? The fasting should be 60 to 95. The 1 hour sugar should be less than 140. 2 hour sugar should be less than 120. So these are my target. If at all anything is above, I will start the patient on metformin. I will go for 1 gram BD. It is not controlled. I will straight away start with insulin in gestational diabetes because I want a very, very strict control in gestational diabetes to prevent both maternal and fetal complications. And in type 2 diabetes, if at all he presents in a complication state like diabetic ketoacidosis or HHS or infection, etc., then in type 2 diabetes, if the patient has OHA failure, be it primary OHA failure or secondary OHA failure. So what is this OHA failure? OHA failure primary means at the beginning of the diagnosis of type 2 diabetes only, his OHA is not able to do the work. Secondary means he has initially responded to OHA for some time. Now he has not been responding even with the 3 drugs combination. That is called a secondary OHA failure. Then during an acute stress, if you are posted for a surgery, if you have got an infection, if you have got a trauma, especially you need to go for insulin. Chronic renal failure, better to keep them on insulin because of very high risk of hypoglycemia with the oral agents, and use of parenteral nutrition. And if there is a weight loss of more than 10% of body weight, better to keep them on insulin. I was giving you the example of 40 kg person at 40 year kept on dapagliflozin and metformin. So these are the very, very important things. But apart from this, as I told you, the beta cell preservation is being a very important thing right now, which we focus on diabetics. So any time the insulin is best for diabetes mellitus. So my question is, when will you counsel the patient for an insulin therapy in diabetes, especially for type 2 diabetes? When you are sitting in an OPD, you are daily seeing the patients of diabetes. When will you start the insulin therapy counseling? So this should be done from the beginning and in every visit. Every visit from the beginning should be counseled for the insulin therapy, because if he is a diabetic, irrespective of type, he is going to need insulin one or the other times in his lifetime. This is the rule. So now coming to how you want to give these insulins. So we know that what are the insulins which are available in the market. Now the problem is how you give the insulin. So there are 2 types of giving the insulin. One is an augmentation therapy, another one is a replacement therapy. So as the name suggests, it is no brainer. An augmentation is the patient is already on some treatment. You want to augment the drug effects. So this is for a type 2 diabetes. The glycemic failure is there on the oral medications, and there is some residual beta function left, but it is insufficient. So this can be by the various regimens, either basal or bolus, depending on either fasting hyperglycemia or postprandial hyperglycemia, respectively. And the dose is very, very important. If at all you are going for an augmentation therapy, it is usually 0.1 to 0.3 unit per kg. Very, very important. So what is a replacement therapy? When there is an absolute failure of the beta cell is not at all functioning. So where it occurs in type 1 diabetes and advanced type 2 diabetes. And the patient needs an intensive control for those who have failed augmentation therapy. So these are 3 indications where you use the replacement therapy. So you have to give this insulin completely from the exogenous source. So the dose is much higher here. It is usually 0.6 to 1 unit per kg. Especially for type 1, we usually start at the dose of 0.5 units per kg when we start the insulin. So it is usually given as a basal and bolus regimen, plus some corrections according to the SMBG. So what are the regimens which are available for the type 1 diabetes? So what are these replacement regimens? So we have to replace the insulin in the human body completely. So what are the human replacements, insulin replacements you should replace? You have to give 1 basal acting insulin, and before every meal you have to give a prandial insulin. So there are 3 types of giving this. One is a conventional insulin regimen. So here what is given is, the conventional means this is for Indian settings, where it is for lesser price. That means we cannot use insulin analogs because they are costly. So what we give is, we give fixed doses of NPH twice daily, and we give fixed doses of short-acting insulin twice or thrice daily. So this is a conventional regimen. Although we usually does not go to this conventional regimen, this is being given only for a very poor patient who are not at all affordable for a very long insulins. That is insulin analogs. So what is the best regimen for this type 1 diabetes is an intensive insulin regimen, where we go for a basal bolus regimen. What is a basal bolus regimen? To mimic the physiological basal secretion and the bolus secretion after each meal. So this can be done. An example is, I've given patient the glargine at the night time, and before every meal I will give him regular insulin. Or if it is affordable, I will give him either insulin list pro or aspart, or if it is definitely affordable, then I will give him FMAS, that is ultra rapid acting insulin, for every meal. Then I will give either any long acting, you give either glargine U100 or U300, or you give him his digludic, or you can give him his detimer twice daily. If the patient is extremely affordable, then you can go for this subcutaneous continuous infusion via insulin pump. One of my patients presently is on pump in the ward. I will try to get a video of this. I have told my junior to make a video of this. But this class, I will not be able to cover how the subcutaneous continuous insulin infusion work. So basically, it acts like your pancreas, which is outside the body. So we have got a machine, we have got an insulin fitted into it, we have got a wire, it is connected into the patient. So what it does is, it secretes insulin at a very low rate. It goes on secreting insulin at a very late, and before every meal, patient has to get a bolus of this. So there is a button, they have to press the button, they have to set the unit. For example, I have set the bolus insulin at 0.1 unit per kg, like the 1 unit should be go per hour. So it will go at 1 unit per hour. For every meal, I have set it at 8 unit. So every meal, it will take 8 unit boluses. So it will be done by automatic thing. So nowadays, we have got this pump, which is internally connected with the CGM device. So you need not give this button, or manually you need not press the button. It will directly read the CGM readings, and it will itself push the basal insulin depending on the your meal pattern. So this is what is the intensive insulin regimen for type 1 diabetes. The best regimen is this for type 1 diabetes. It is affordable, go for insulin analogs. If it is very, very poor, cannot be able to afford even a long-acting insulin, go for conventional regimen with a 2 doses of NPH per day and a 3 doses of short-acting insulin thrice daily. And what is a modified insulin regimen? So modified insulin regimen is not advised. In a very extreme conditions, we use this. So how you use this? You at the breakfast, you are giving a combination of NPH and a rapid-acting insulin. So it acts for around 12 hours. Then in the dinner, you give insulin glargine or detimer with a rapid-acting insulin. So there are only 2 doses possible here. So you are reducing the number of doses, but the glycemic variability is increased and the risk of hypoglycemia is increased with this. So how the procedure is, you need to determine the daily target dose. How will you decide this? So total daily insulin dose for the children with a newly diagnosed diabetes, generally it is 0.3 to 1 unit per kg. So I remember it as 0.5. So you can use a little bit higher doses if they are pubertal children, if they are a growing age, if the patient has recently recovered from the ketoacidosis, or the already on the steroid therapy. Sometimes they are a little bit obese also. So these doses are titrated up and down as it depends on the patient response. So what we do is we take this total insulin dose. For example, if the patient is 30 kg child with 0.5 insulin or 1 unit, I have decided to give 1 unit per kg. He has recently recovered from TKA. So I have to give him 30 units. His target daily dose is 30 units. So I have to divide this into 2 parts. One into basal insulin, another into prandial insulin. So the 40 to 60% of this insulin, I give it as a basal insulin, and remaining 40 to 60%, I give it as a total dose. So like, let me make it 50-50 to calculate here. So I will give basal insulin of 15 units and prandial insulin of 15 to 16 units. So this basal insulin is to be administered once daily, depending on the insulin glargine, detimode, or degludec. If I decides to give an NPH, so I have to give it this 15 unit twice daily. So I will give it 8 unit in the morning, 8 unit in the night. So whereas prandial insulin, the 16 unit, I have to divide it into each meal. I have to give 1/3 of this before breakfast, 1/3 of this before lunch, 1/3 of this before dinner. So after doing this, you need to calculate this doses depending on the carbohydrate intake, and you can adjust this insulin with the prandial dose as needed for the preprandial hyperglycemia, and better to go for the rapid acting or the ultra rapid acting insulins. So the insulin doses, especially in children, it may vary each day depending on the food intake. So any corrections for the glucose above the target range should be advised them. So basal insulin we give usually once or twice daily. Some children it is better to give divided doses, because those who tend to have a nocturnal hypoglycemia, hence detimode is used. So insulin degludec may also be used. So it has longer duration of action, but still given once daily. So hypoglycemia can be very, very problematic hindrance in treating the type 1 diabetics. So type 1 diabetics, actually it is simple. There is no other choice. You have to go for an insulin. You have to just know how much insulin to give and how to give. It is a basal bolus regimen. There is no second thought about it. Whereas type 2 diabetes, if you say in excess of 50% of people with type 2 diabetes will require an insulin injection at point in this life, like 50% is very less according to me. I will go to 90%, especially in Indian part of section where the diabetes is usually diagnosed late and very negligent people does not understand the importance even after explaining a lot of quackery. So 90% of people do get insulin in their lifetime. So what are the insulin regimens for type 2 diabetes? We have got the first line regimen and we have got second line regimen. We know that type 2 diabetes, there is no absolute insulin deficiency. The beta cell function has definitely reduced. It is insufficient, but there is some reminiscent available. So that is why the first line regimen is basal only regimen for type 2 diabetes. This is a very, very important thing and a very famous regimen of my personal favorite. Many of the patients will be controlled only on one single dose of basal insulin. Only if this regimen is not working, you have to go for a second line regimen for the type 2 diabetes. What are these? You can go for either pre-mixed regimens, or you can give basal plus regimen. That means you are giving basal plus either 1 or 2 doses of prandial insulins, or the intensive insulin therapy as basal bolus regimen if nothing works. So again, to understand the times here, the first line regimen is the basal insulin only regimen. This can be given either at a insulin analogs or using insulin NPH. So what is the, if you use an NPH, you need to give 2 doses at least. Whereas if you use the long-acting analogs, you can give a single dose. So this is a glargine insulin. If you use a basal insulin, you can use either the U100, but it is better to use U500, or you can use the degludec insulin for the achievement. Or if you are using NPH, it is usually a twice daily administration of a basal insulin. The second line regimen, as I told you, it is usually as a pre-mixed regimens. So you are using either 30-70 or 50-50 of regular and NPH, or you can use either Novomix, or you can use either Rhizodec. So you are giving the insulin rapid acting before each meals, and you have got a long acting insulin coverage. If it is, again, if it is analog, you are giving OD dosage. If it is NPH, you are giving it as a twice dosage. So how will you start this insulin in type 2 diabetes? So you need to start the patient with either bedtime insulin, or a morning long-acting insulin, or an intermediate acting insulin twice daily. The tendency is to go with, start with either 10 unit directly, Or if you want the per kg dosage, it is 0.1 to 0.2 unit per kg. I usually go for 0.2 unit per kg. Sometimes you can use a very higher dose also. If the patient is very much obese, like 110 kg, if you use him 0.2 units or 0.1 unit, it will be only 11 units. So that is very wrong dose to use for a patient who is very much obese, have a very high insulin resistance. So go for a little bit of higher dose because these are peakless insulin. There is no problem with the hypoglycemia. So after this, remember when we give the basal only dosage, what we are targeting is the fasting blood glucose. The basal insulin takes care of only fasting blood glucose. The postprandial care is not covered because we know that the insulin is secreted at a basal rate to suppress hepatic gluconeogenesis, which is the major point to control fasting glucose. If you want to control the fasting glucose, you need to suppress the hepatic gluconeogenesis. That is what is done by the basal insulin. If you want to suppress the prandial insulin, that is postprandial insulin, you need to give the short-acting insulin. So whenever you start the patient on this long-acting insulin, you need to check their fasting glucose by the SMBG daily. So you need to achieve the target. What is the target here? 80 to 110, some believe, but it's okay. 80 to 120, 130, you need to achieve. Very easy to remember is 80 to 120. Until you achieve this 80 to 120, goes on increasing the units by 2 units every third day. So patient came to you on Monday, you advised him to take 10 units. Ask him to check fasting every morning. If it is coming in less than 120, it's okay, continue. If it is not coming, goes on increasing insulin by 2 units every third day, like make it 12 units on Thursday. If it is not controlled, make it 15 units on maybe Friday, Saturday. So like this, you need to go on increasing the dose till you get the target. You can also increase in a larger increments by 4 units if it is too high, like especially if fasting is coming more than 180. And if hypoglycemia occurs, you need to reduce the dose by 4 units. This is what is important. And if for example, patient is kept on fasting blood glucose, basal insulin, his fasting is controlled. He came to you for the follow-up of 3 months. His A1C is still more than 7. And if his fasting glucose was in target, you need to check the patients for pre-lunch, pre-dinner, and pre-blood sugar, depending on the glucose results. And depending on this, for example, if the patient has subsequent persistent pre-lunch glucose, then you may add a rapid-acting insulin at a breakfast. If it is persistent pre-dinner glucose is high, you might add an NPH at the breakfast or a rapid-acting insulin at lunch, depending on what you want. So pre-bed insulin, if it is very high, you may add a rapid-acting insulin at dinner. So if it is still very high, then you need to keep the patient sometimes on an intensive insulin regimen. So this is how we usually proceed. But believe me, more than 50 to 60% of the patients are very good at this level. With a single basal dose, they are very much controlled. And whenever you add this insulin of a basal dose, you may not stop the OHA. This is in addition to whatever the drugs he is on. So we know that we add insulin only when 3 drugs fail. So the 3 drugs can be continued even with this basal insulins. So definitely when you give insulin, there is some amount of troubleshooting will be there. The hypoglycemia is very important. It is very common in type 1. But type 1 diabetes, even with proper type of insulin, proper regimens, they usually experience hypoglycemia at least 1 to 2 per week. It is accepted for type 1 hypoglycemia, diabetics. And the basal insulins are much lesser in causing hyperglycemia compared to the prandial insulin. What it might do is it might cause an obligate eating, especially in children, or it is also called as compulsive snacking. So this may add to the weight gain caused by the insulin. So what do you do if there is a nocturnal hypoglycemia? If patient is on NPH, you may change him to long-acting analogs, and you may have to reduce the nighttime dosage by 4 units or 10%. If you cannot identify any precipitants, like patient does not consume alcohol, no skipped meals, etc., sometimes you may have to decrease the dosage by more, like 20 to 30%. And if there is daytime hypoglycemia, and if the patient is taking prandial insulin, you need to reduce the dose. Or if the patient is taking sulfonylureas, you need to reduce the dosage. And insulin dose resistance, whenever you see the encounter the insulin resistance, sometimes you may require more than 200 total units daily. So the concentrated insulins can be used in management, like U500 regular can be used, U300 can be used, where a similar amount of insulin contains more units. And another important effect is the insulin induced. The patient should be advised about the weight gain, especially if they the diet. The major emphasis is again to be on the diet and lifestyle modification. The weight gain which is occurring in the patient may again increase the insulin dose, leading to vicious cycle of insulin resistance. So this is multifactorial. Patient may continue dietary indiscretion because now you are telling that you are adding an insulin. Patient might feel that already I have added insulin, why I need to reduce the meals, etc. Or sometimes there may be a subconscious snacking, like they don't know that they are getting hypoglycemia, that just that having a tendency to eat a lot. Sometimes they do it consciously. Sometimes they're doing it for over treatment of hypoglycemia. So they use this hypoglycemia for their primary or secondary gains. So that will add for the weight gain. There are two important phenomena which you should remember, or dawn and another, which are two different but at similar kinds of scenarios. Both have the early morning hyperglycemia, but the cause is different. In dawn phenomena, it is due to normal increase, a normal morning effect of this counter and hormones. So we need to increase the medication, increase the basal doses. There is a treatment of choice. Increase the nighttime insulin dose, whereas Somio is different. Where was I?
Yes, sir. At the last time, the Somogi phenomenon you were explaining and the dawn phenomenon you were comparing between those two. Um,
Where was I?
yes, sir.
And
So your audio is breaking in between, sir.
Right now, is it?
Yes, sir. So now you are audible and clear. So the point where the Somogyi phenomenon versus the Dawn phenomenon you were explaining, yeah, this point itself.
Yeah. So the treatment for Down phenomenon actually to dosage, whereas for the Somogyi it is opposite. You need to reduce the nighttime dosage. To know this, you need to take the overnight blood sugar, the 2 to 4 a.m. blood sugar. If it is going into hypoglycemia, then it is a Somogyi. If it is normal, then it is Down phenomenon. So this is my own patient who was on CGM. He came to this me with this CGM report. So see this patient going into glycemia with the early morning hyperglycemia. So this patient was on NPH actually because he did not get the Diglodec. The availability was the issue, so we kept him on NPH. So this patient came to us with a Somogyi. So whenever we take the insulin with OHA, you need to know what to do with the drugs. With the metformin, there is no problem, you can continue. If the patient is on insulin secretagogue, there is no problem in continuing, except that you need to explain the risk of hypoglycemia is very much high. If the patient is coming with an insulin-induced hypoglycemia versus if the patient is coming with the glimepiride-induced hypoglycemia, which I am more worried is the glimepiride-induced hypoglycemia because it's a very long-acting. The patient will go into hypoglycemia again in the next 48 hours. Whereas if it is insulin-induced, it is just for the hours for which the insulin is there. Like if it is NPH, it is just for 12 hours. Whereas if it is 48 hours in glimepiride-induced. That's why the insulin secretagogues. The natagaline and rapagaline, there is no problem. Especially they are used as a mealtime the secretagogues only. But long actings like glimepiride, you need to be very, very careful. The insulin with pioglitazone, the very much problem is the weight gain. They have got an additive effect in causing the weight gain, and sometimes they may together worsen your cardiac failure. So I usually stop pioglitazone or at least try to reduce the dose. The DPP inhibitors and the SGLT2 inhibitors, there is no problem. You can continue irrespective of the dosage. So few practical aspects of the insulin therapy to go. The insulin syringes, you need to understand there are two syringes which are available, U40 and U100. Remember, whenever you use an U100 insulin, you need to get U100 syringe only. You cannot take U100 insulin from the U40 syringe. A very, very wrong thing to do. Then you will overload yourself with the insulin. How to identify the insulin syringe? The red is U40, the orange is U100. There has been a lot of controversy to change the color of the cap just because some people may not differentiate between orange and red. But remember, the U40 units has only 40 mark and U100 has got 100 mark. And always try to use the similar type of syringe compared to the concentration of the insulin. And this is for the insulin needles. So they need to be taken off after a single use. This is ideal. So this is this is before use. This is after single use. Even with a single use, there is a blunting occurring, and this is after 6 uses. So what is this? Is if you're go on taking this insulin with this syringe, so this will not only deliver the insulin but will also tear the subcutaneous tissue. So over a period of this, what happens? It will cause your lipodystrophy or lipoatrophy or lipohypertrophy, whatever it is. Along with this, the subcutaneous tissue get fibrosed, and you may go on increasing the insulin dosage. If you are giving 10 units, since due to fibrosis, only 6 units is getting absorbed. So these are the problems which occur with insulin syringes. Be the syringe or the pen, you need to be very careful. The ideal thing is to change insulin needle every use. But we know that this affordability is the issue. The one that is around 10 rupees and it is around 15 rupees. You cannot change these syringes for each single use. So ask to change at least after 3 pricks. That is what I usually advise. Or another best advice is change if it pains. The insulin syringe should not pain. If it pains, then you need to change the insulin syringe. So what are the steps with the insulin injection? You need to wash the hands before to prevent the infection. We have seen a n number of patients coming with abscess at insulin site. You need to get your supplies. First, you need to roll the insulin vial between your hands. If using a cloudy insulin, which is a cloudy insulin, if it is an NPH, or if it's any insulin, if it is seen cloudy, just you roll the insulin just to prime it. Then you need to wipe the top of the vial with an alcohol swab. Remember this, not the skin of the patient, it is just the alcohol swab with the top of the vial to prevent any contamination. Because you have kept on the fridge, you have kept it on some container, you need to be very, very careful. So now you need to pull the syringe down to the desired unit first. Remember it. Next, insert this into the vial, then push the plunger, push the equal amount of air which you want to the vial. Like if you want a 10 unit, draw it till the 10 unit and push the 10 units of air into this syringe. Then turn the upside down, pull the plunger down to withdraw units, because this will cause an exact number of units to come when you pull. Then if there is any air bubble, you need to remove the air bubble. Then you need to clean the injection site, but not with the alcohol swab, just with the distilled water. Then you need to inject it, and after injecting it, you need to follow a 10-second rule. Ask the patient to count for 1 to 10. Don't tell them to count for 1 to 10. Tell them to count for 1000, 1, 1002, 1003, like this. If you ask them to count for 1 to 10, what they do is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. They will remove it just a 2 to 3 seconds. So some unit may get discarded outside. So this is a very, very important thing. As far as site is concerned, there are two preferred sites. Basically, one is an anterior abdominal wall and the lateral thigh. Some people also go with the upper arm and the gluteal region, but I usually not advise them. Usually go for either abdomen or lateral thigh. So in the abdomen, always change the site. Like this is what I again have got a picture of this in my OPD for diabetic patients. They have to keep on changing this site daily, so that by the time they comes to the original site, it's already been 2 weeks, so it does not pain. Or there are other patterns also. You can use a horizontal pattern, you can use a curve pattern, you can use a crisscross pattern, zigzag, anything. But ask them to change this site daily. So how will you store the insulin? It needs to be stored in the refrigerator, but should not be freezed. It is to be kept at 4 to 8 degrees Celsius in a refrigerator. Must never be frozen. Never expose this to the direct sunlight, especially the summer condition. Extreme heat can damage insulin. And another advice which I usually advise to patient is never order insulin from online pharmacy. So ordering of insulin from online pharmacy is definitely not advised, because the cold chain maintenance is very poor in case of an online delivery systems as far as insulin is concerned. You can order your drugs, you can order your tablets, no problem with it. But insulin, it is better to take with the nearest the medical shop which is available to your home. This is what I usually advise. And if the insulin is more than a month, it is usually better to discard them. And if it is kept on 4 weeks at a room temperature, don't use it. So the pharmacy should be very, very strict in maintaining the insulin in a very proper cold chain systems. Now you have got insulin pen devices to make the delivery of insulin very easy. So there are some pens, like reusable pens are available, and some disposable pens are available. Like patient is, if you want to use some specific type of insulin with a pen, you can give this disposable pen. So after the vial is over, you need to discard this insulin. You cannot reuse this. But this reusable insulin have got the place for a cartridge, and insulin. So these are the parts of the insulin pen devices. You might have already know this. This is very easy to use, very handy to use. some case studies I have given in the presentation. You can go back when I give you the study. So now some new insulins are available in the market. Especially I was telling about this Rhizodec. So this is 70% of degludic and 30% of aspart, which is present in a dihexamer form as far as degludic is concerned. So aspart hexamer is there. So aspart gets immediately rapidly dissociated with the subcutaneous tissue and the capillary membrane, whereas degludic goes very slowly. So this can be used, but the price is very high. I was telling you it is around 2,000 rupees per cartridge itself. Then we have got a combination. This is a fixed dose combination of and long-acting insulin with a GLP-1 analog. So we have got this IDEC-Lira, or the trade name is Zultrophy, which contains the 50 unit of degludic per 1.8 mg of liraglutide. So this is seems like a very promising thing, especially if the patient is having the both fasting and postprandial hyperglycemia. The postprandial is taken care by the liraglutide, the fasting is taken care by the degludic. And this hepatoselective insulin, I was telling you this that whenever we give insulin, we directly delivering it to the systemic circulation, so that the availability to the liver is very, very reduced. So what we are doing is we are attaching this pegylated, we are doing this pegylation. The polyethyl glycol is attached to the Lispro insulin. This is one of the experimental drug available right now, the PEG Lispro. So this, whenever we give insulin, the peripheral cells cannot utilize this. This can only be utilized or recognized by the liver and is uptaken by the liver. So this is the ongoing study. And another insulin is smart insulin delivery using glucose responsive insulin analogs. So we need to give this insulin in a closed inactive state. So whenever it gets inside the body, it recognizes the ambient glucose, then it secretes insulin. If it is very high, it gets on and it secretes. If it is very low, it automatically gets off. We need not do anything. So this is called as the glucose responsive insulin, a very big thing coming right now. We need to see how it goes on. Then again, coming to this inhaled insulin, this has been FDA approved, but there are a lot of problems. Taken like a rapid acting insulin before every meal, the patient has to go. The pulmonary function test should be normal. The cough is very, very common with this insulin. The price is very, very high. The dose adjustment is very, very difficult with this inhaled insulin. Another advance is this iPort. This iPort is to reduce the pain at the injection site. So you have got a iPort which is being applied to the skin. So every time you need to inject it into the iPort, so it will deliver the insulin painlessly to the subcutaneous tissue. So this is another recent advantage. This one. So these are some famous personalities, especially the Kamal Hassan and Fawad Khan. These both are type 1 diabetics. So remember, the people, whenever they get diabetes, especially type 1 diabetics, they lose hope that they cannot survive, they cannot lead the normal life, they cannot get married, they cannot have children, they cannot do work, etc. So, but believe me, this person is on insulin since the beginning. So you need to have a lot of courage in managing this type of diabetes. So let me take these two questions also here, a little bit time left. So the 58-year gentleman is working as a lawyer now to have type 2 diabetes for 10 years. Also hypertension, dyslipidemia, on metformin 1 gram BD, glimepiride 4 milligram BD, sitagliptin 50 mg. So already on maximum doses of this drugs. With that, his fasting is 210, PPBS is 280, HbA1c is 8.5. So what is this? How will you advise is, so this is an uncontrolled diabetes with a risk factor, being on maximum dose of OAD. So I need to start them on augmentation therapy. That is, first is the basal insulin, like either glargine or degludic. So what is the starting unit? I want to start them with a 10 unit insulin. They have not given the weight of the patient here, or 0.2 you can start. So you can continue the existing OADs, except that you need to explain the risk of hypoglycemia because he's on glimepiride 4 mg PD. Then educate on self-monitoring of blood glucose, ask him to take fasting daily. Target fasting is 80 to 120 and fasting postprandial 120 to 180. If on follow-up, fasting is controlled, but postprandial is not controlled, you may consider a single rapid-acting insulin, depending on that hyperglycemia. Then again, to take a case history here, a 16-year-old boy who's working in a mason presents with a history of polyuria, polydipsia, and weight loss, typical symptoms of diabetes. a 6 kg of weight loss over 3 months. Labs show that fasting 280, postmortem 380, HbA1c 10.5, GAD antibody positive. So he's type 1 diabetic. There is no doubt how to manage. So if it is not, he's not in DKA, he needs a replacement insulin therapy as a basal bolus regimen. This is the first and the best regimen. So I will add a short-acting insulin or an insulin analog as a bolus insulin, and a long-acting insulin or an NOx or an NPH for the basal coverage. So what is the dose I usually start? I usually start at 0.5 unit per kg. So it can be split as 40 to 50% as basal and 60 as prandial coverage. Educate them on the diet, educate them on physical activity, importance of SMBG. And type 1, you need to give them that you are going to have hypoglycemia, how to manage hypoglycemia. Ask them to have this glucagon injection, which is to be taken like insulin only in the home to prevent the death, especially, and they need to titrate the insulin accordingly. I think, although I did not cover all the things which are coming with the insulins, when I take the diabetes as a whole, it is better to understand. So I have decided to take this diabetes as a whole from now on. So I will put the hematology department after this. So since because of started insulin therapy, let me take few important aspects regarding to the diabetes in this classes. So I want all of you to go and study again to understand the insulin therapy better. So this class might help you to understand easily rather than completely knowing the subject. Thank you.
Yeah, thank you, sir. The class was a very wholesome topic.